Okay, thank you very much. I guess I'm going to start because I have the toughest claim to make, but this is a very prevalent claim by many cardiologists that actually coming with the question, why can't we stop with an echo in pulmonary hypertension and not necessarily continue to right heart catheterization? And I'll try to support this concept as much as can be. So what is the status right now? The status right now that in the current guidelines, echocardiography is a screening tool for patients with suspected pulmonary hypertension using the TR jet velocity to assess the systolic pulmonary pressure, and with several couple of other parameters help you to re-stratify and concentrate in the patients who are going to or are suspected to have pulmonary hypertension. However, when you look at the guidelines, it doesn't matter how you start. The main cross is this one, and you can't overcome this main cross, and you should perform right heart catheterization no matter how you start and no matter what the echo suggested. So the question is, right heart a luxury or a must? Or a different way to ask the question is, when enough is enough? So what do we actually really need to know in patients with pulmonary hypertension? We need to confirm the diagnosis of pulmonary hypertension. We need to get some data about the etiology. We need to confirm accurately the filling pressure, obviously to do a reversibility test, and to have some data about prognostic parameters, which is mainly the cardiac output and to some extent the mean RA pressure. And the issue of the cardiac output is a key factor because although the pulmonary people are usually the one who treat the patients with pulmonary hypertension, the cause of death and the main morbidity and mortality is coming due to cardiac reason, which is right heart failure due to low cardiac output, and this is a key target in the treatment as well. So we need to be very careful when we are going to ask ourselves, can the echo deliver? Because we know that certain people and certain measures that looks as they can deliver fade over time, and you have to be very careful, as you can see on the picture on the left. But obviously, echo can have a lot of information about the etiology, obviously shunts, heart failure, valvular disease, etc. Obviously, it can't deliver the issue of reversibility test, but I would claim that, I would argue that actual reversibility test is only positive in up to 15% of the patients, in the very minority of the patient, and usually is associated with idiopathic pulmonary hypertension and anorexic drugs, so this is not a major issue. The main issue is, can the echo deliver reliable measurements regarding the pulmonary pressure, the filling pressures, and obviously eventually to get the cardiac output correlation. This is a study from Jack at 1997, which shows a very good correlation between tissue Doppler, done on the mitral valve obviously, and actually gold standard LVDP / wedge pressures. And as you can see, the correlation was pretty good. However, I will be the devil advocate and would suggest and show you another study done in Circulation, 2009, in which heart failure patients who were candidates for CRT implantation, this correlation between the echo measurements or the echo assessment was actually poor with the numbers that you got on right heart catheterization. So we have these two very different setting of data, and as you can see on figure A on the very right of your slide, there is a good correlation, and the second study, which is actually showing poor correlation. So which one is true? If you go to the second study of Mullens in Circulation, and you look at what substance of patient he was coping and measuring, actually they were patients with advanced heart failure. Moreover, there were patients with decompensated heart failure. There was a significant mitral regurgitation, and the decompensated heart failure you could see on the parameters of the hemodynamics with a low cardiac index and high LV volumes on their parameters. And indeed, when they looked which parameters did influence the lack of significance between the echo and the measured numbers, these were the two measurements that were dissociate the echo correspondence with the hemodynamic measurements, which means if you had elevated LV volumes and if you had low cardiac output, then there was a dissociation between the echo assessment and the right heart assessment. Now, keeping this in mind, I would argue that these patients are not the focus of our interest, because obviously we're talking about patients who are candidates for treatment in pulmonary hypertension, i.e. patients with pulmonary arterial hypertension, and obviously patients with heart failure, especially those with decompensated heart failure, are not candidates for this treatment. So the whole issue of echo versus right heart is not relevant in these patients. And if you really want to make sure that these patients are having heart failure, you can use either natriuretic peptides and other clinical parameters to make sure that you can sort out only the patients who are relevant for right heart, who are relevant for treatment, and then to have the echo and get the echo measurements and go with these echo measurements. What about echo and RA pressure? Many studies, mainly used and delivered through the IVC, both dimension and collapse in Inspirium, and found more than fair correlation between the MRA in the echo and the actual numbers that you had on hemodynamics. This is a study that compared many parameters that the echo people are using, the echo teams are using in assessment of the RV function, and compare it to kind of another gold standard, which is MRI. And as you can see, the MRI data that was compared to was a very important LV mass index, LV ejection fraction, and RV ejection fraction. And as you can see, the areas under the curve of these parameters, of these different parameters, was pretty high. Most of the curves were on the very left side of the figures. And it depends on the RV function, but in any case, you could have some echo measurement that were predicted or correlated very highly with those on the MRI. Now let's go to numbers. This is a study done on 40 patients who were transplant or LVAD candidates. And as you can see, the numbers that you got on echocardiography comparing to the right heart failure were very, very similar. 9/10, 28/31, etc., with high correlation numbers and significant p-values. And it really doesn't make any difference, I think, in your treatment agenda if the true gold standard MRA is 9 or 11. I think that even if you're going with 2 millimeters, 3 millimeters mercury to each side, even though it may look like the R wave, maybe the R correlation is going to be higher, it's not going to make any practical influence. Now, one should keep in mind that right heart catheterization has its own disadvantages. First of all, this is an invasive procedure. In the ESCAPE trial, there was more than 4% direct procedure complication, which obviously you don't have in the echo if the patient doesn't fall out of his bed. You have an issue of the cost, which is significantly higher in the right heart comparing to an echo. And the third one is not less important, and this is a logistic issue, because if you are claiming that right heart is the only way to go, and you need the right heart in any stage for assessment and direct you in the therapy, then you may need to repeat the right heart at different stages of the treatment. If you double it or triple it or whatever you need to do in the number of patients, then you get huge overload on the system. So there is a significant to what measures you can cope with if you are claiming that right heart is the only way to go. So in conclusion, I think that it's fair to say that echocardiogram is a reliable non-invasive test to assess pulmonary hypertension and relevant hemodynamics parameters. It may serve as a tool for screening, detection, and follow-up in pulmonary hypertension patients, including patients with arterial hypertension. So again, and finally, when enough is enough, sometimes you just know that enough is enough and you should stop there and find out the Thank you very much. Okay.